bypass surgery, revascularization of choice, or last resort. Viv?
Thank you, Barry, and I hope your legs are okay. And I want to thank my two previous speakers. It may not have come across, but Peter Seidlin, although he showed you some fantastic cases, really has a strong head on his shoulders, and he really glossed over it, but we really do collaborate actively between the surgeons and the interventionalists, and we do what we think is right for the patient. Sometimes we disagree, and we get a third arbitrator in, but I want to say kudos to both of my previous speakers. I also want to comment on something that Leonard said. My twin girls just celebrated their 11th birthday, and I think given my cultural background, it's an amazing generation advance that I'm not speaking at their engagement party tonight. So for a disclosure, I am a cardiac surgeon. I have various advisory positions as well as some research support. None of these companies are in the business of coronary artery disease, though. We haven't really talked about the most recent guidelines that have been widely published, and this came out in the November issues of most of the major journals. I just gave you the circulation quotation here. But it really looks at the optimal treatment of coronary artery disease, whether it's medical therapy, PCI, or coronary bypass surgery. And this is a Class 1 recommendation, level C, that a multidisciplinary heart team approaches revascularization in patients with left main or complex CAD. And I think Len brought up this point that really for single vessel disease, medical therapy is excellent. Peter brought up the point that if they're having protracted symptoms, PCI is a reasonable option. But when we're talking about revascularization strategies, PCI versus Cabbage, it's really these left main complex CAD patients that we need to discuss. And again, the recommendation is we do this in a multidisciplinary collaborative fashion. But what does this mean? What does a Class 1 recommendation mean? It means that there's evidence from at least one randomized, properly controlled clinical trial. And level C evidence means that there's at least fair scientific evidence that suggests that there's a benefit by the clinical service. And this is for PCI. The balance between PCI versus surgery and the risks of the various procedures in this particular setting are too close for making generalized recommendations. So it's a level 1 Class C recommendations. Basically says, get experts together in a room, look at the patient, consider the anatomy, consider all of the various patient-related factors, and then make the decision that's appropriate for that individual patient at that individual time. So let's go a little bit through what the evidence is with respect to PCI versus Cabbage, and I'm going to try very hard not to make this into a debate-type format. But I'm going to concede this, and Peter showed you this data already. There's no question that angioplasty of a culprit lesion has been proven time and time again to be a value in ST elevation MI, reduces mortality in strokes and likely reinfarction. It's also very useful in high-risk, non-ST elevation acute coronary syndromes. And I concede that in both of these acute conditions, timely PCI in these selected patients has been a fundamental advance in the treatment of coronary artery disease. But I want to restrict my arguments to the discussion of the semi-urgent or elective patient who comes to us with multivessel disease. And again, Peter showed you the history of revascularization for coronary disease. I'm going to show you a series of meta-analyses that looks at the various evidence pooled together. And this is PCI versus medical therapy, published in the British Medical Journal in 2000. And what's interesting here is that really no benefit to PCI over medical therapy in a combination of these 6 randomized controlled trials, looking at over 2,000 patients. As Peter said, it's very good treatment for angina, but in terms of death, no benefit to PCI. Future revascularization, you're actually more likely to have PTCA if you've had a previous one. And surprisingly, if you have PCI, you're actually more likely to require Cabbage in the future as opposed to if you stayed with medical therapy as the initial treatment. So the conclusion of this meta-analysis is that PCI should only be used in patients whom angina cannot be controlled by medical treatment. And he's a cardiologist that wrote these guidelines. Cabbage is an acceptable alternative. Again, Len did not show you some of these slides, but aggressive medical therapy versus PCI. Again, these are data that were accrued in the early 90s and published in 1999 and 2004, comparing either a statin medication or, on the right-hand side, exercise therapy. We heard about that yesterday. So again, prognostic benefit to both of these treatments, superior to that of isolated angioplasty. But as Peter will keep telling you, that was then. This is 2012. The technology has changed. We have to look at more current data. So what's the evidence between plain old balloon angioplasty or POBA versus PCI with stenting technology? Again, another meta-analysis by a Canadian, this time out of Quebec, published in the Annals of Internal Medicine in 2003, looked at 29 randomized trials involving almost 10,000 patients, again, comparing PCI with stenting versus plain old balloon angioplasty, and you'll see that there's no difference in prognosis, whether it's death or myocardial infarction, no difference in the need for subsequent coronary bypass surgery, but stenting does have a significant benefit with angiographic restenosis in that target vessel and a significant benefit for the requirement for repeat PTCA, probably again due to that oculostenotic reflex that Len mentioned. So again, the conclusion of this meta-analysis is that PCI with stenting has no impact on mortality or subsequent myocardial infarction, but that routine stenting at the time of PCI prevents 4 to 5 repeat PCI for 100 patients that you stent. What about drug-eluting stents versus bare metal stents? Another meta-analysis published in The Lancet in 2004, looking at 11 trials, over 5,000 patients. Once again, no difference in death, no difference in subsequent myocardial infarction, but once again, the drug-eluting stents, the advances in technology is improving the efficacy of the actual stent, so your angiographic restenosis was dramatically reduced, and the target vessel revascularization was dramatically reduced. And I'm going to come back to some of these terms because I'm not sure, as a cardiac surgeon, they confuse me. I'm sure they're confusing you as well. What about the high-risk PCI patient? Is the drug-eluting stent, in this case the sirolimus stent, better in patients with diabetes mellitus, which have been proven in previous trials to fare poorly with PCI? Again, a meta-analysis of 4 randomized trials, almost 600 patients, no benefit in patients, high-risk patients with diabetes with death, a combined endpoint of death or infarction, no difference in the incidence of stent thrombosis, but again, the drug-eluting stents in patients with diabetics reduced the need for repeat revascularization. But what is the actual relevant endpoint? I mean, when you read all of these trials, you'll hear all of these terms. Restenosis of the stent, target vessel restenosis, target vessel revascularization. So let me give you a great story here. So this is one of my patients. He's a 50-year-old male, diabetic, perfectly healthy, presents with exertional angina, and can you just click on that for me? Thank you. And this is his angiogram, very similar to what Peter just showed you, and I apologize if it doesn't project well in the back. But he basically has a complex LAD lesion, doesn't involve the left main, but it starts from the origin of this first diagonal, which is normal, all the way to the origin of the second diagonal, which is also compromised by this lesion. He's 50, he's healthy, he's active, didn't want surgery, and I think appropriately at that point in 2008, he underwent angioplasty. And in 2008, had an excellent angiographic result, and you can see the stent in place here. Our boys at PMCC know what they're doing. Again, it may not project well, but this is a complex stent. It's a bifurcating stent into the origin of that second diagonal and into the ongoing LAD, and had an excellent angiographic result. It's a great success story in 2008. 3 years later, though, he has recurrent angina and presents to hospital with a non-STEMI. Now, if you look at this, and you can see the stent in place there again, the stent's wide open, but he's got a distal left main lesion along with a very proximal LAD lesion. He's got distal disease in the diagonal at the area where this becomes tortuous, likely from the wire that had to go down that vessel to protect the initial PCI. And this is not an uncommon finding. Patient presents with a patent stent, so it was a successful PCI, but he's now got new left main disease. So if you look at the trials, was this a success? Was there stent thrombosis? No. Successful outcome. Was this in-stent stenosis? No. A successful outcome. Was this a target vessel stenosis? Actually, it was. The LAD developed disease, so that's a failure. So depending on what the outcome reported by that particular paper, this would be recorded as a failure. Did this patient have a subsequent myocardial infarction? Yes, so this was a failure of therapy. And did he require repeat revascularization? Yes, it was a failure of therapy. This patient received a single lima, which skipped from his diagonal to that LAD, with a single RITA to the circumflex distribution to treat his left main, and has done very well following surgery. So the question I think that we really want to know is, what does the patient care about? And again, we talked about it at the beginning of the day. His primary concerns, or her primary concerns, are his survival and the freedom from repeat revascularization. In the elective patient with stable angina, PCI has never been shown to have any survival benefit with or without a stent, and whether or not that stent is drug-eluting. So with respect to survival, PCI is not the answer. Compared to Cabbage, PCI is always associated with increased rates of repeat revascularization, and in certain subsets, PCI is associated with inferior survival. So I'm not going to bore you with all of the randomized trial data, but again, if you look to what the patient cares about, survival or freedom from repeat intervention, the data is clear. Cabbage is a superior revascularization strategy. But the patient wants to avoid surgery, and that's what I hear time and time again. The patient doesn't want surgery. Yes, we think that surgery is indicated, but they don't want to have surgery. Does anybody know who this person is? This is Giuliana Rancic. She's a very famous talk show host. She actually married Bill Rancic, who was the first winner of Donald Trump's The Apprentice. She was diagnosed late last year with early-stage breast cancer and had successful curative therapy with a minor lumpectomy and adjuvant chemotherapy. And she made headlines because not more than 2 months later, she came back for a prophylactic double mastectomy. She went for an invasive surgical option that wasn't even indicated because she was frightened of recurrent disease. Well, why aren't our coronary patients like cancer patients? Why aren't they afraid of the recurrent disease? When given the choice, most cancer patients prefer surgery even when we can tell them that it's not a curative procedure. When given the choice, most cancer patients prefer surgery over chemo or radiotherapy, even if we say the outcomes with chemo or radiotherapy are similar. However, when given the choice, most cardiac patients avoid surgery, even when we can prove to them that their outcomes are superior. So that boggles my mind, and hopefully, as primary care physicians, you can convince your patients that they should treat their coronary disease like a cancer because it is recurrent. So let's look at some more subsets of patients who had PCI versus Cabbage. This is the Syntax trial. This was a multinational trial predominantly held in the United States and Western Europe. And I won't bore you with the trial design, but basically there was a registry arm that looked at patients who were only amenable to one treatment approach, but we're going to focus on the randomized arm with a drug-eluting stent, in this case the Taxus stent, versus surgery. Just under 2,000 patients randomized in this trial. And if you look at the primary outcome, which was major adverse cardiac events out to 2 years, you can see that there was a clear benefit to Cabbage. I'll concede, and Peter's going to raise his hand, and those little pinwheels are going to say this is all due to repeat revascularization. But again, that's what the patient cares about. Do I have to worry about coming back a year later for having another PCI because my first procedure failed? So the conclusion of the Syntax trial is that Cabbage remains a standard of care, and I want to re-emphasize that. Cabbage remains a standard of care for patients with 3-vessel or left main coronary artery disease, since the use of surgery, as compared to PCI, results in lower rates of the combined endpoints of major adverse cardiac or cerebrovascular events at 1 year. Again, triple vessel disease comes in many flavors and many shapes. And one of the major benefits of the Syntax study was the development of the Syntax score, which tries to give us some objective way of measuring the burden of coronary disease. And it's not that important if you can't see these slides. The important point is that there's a way now to objectively score what the anatomy is of a given patient. And on the left-hand side, this patient has a Syntax score of 21, considered to be a low risk. In contrast, on the right-hand side, the Syntax score of 52 is a very high-risk anatomy situation. And again, if you look at survival based on their Syntax score, you can see in those patients with a low Syntax risk, a score of 0 to 22, basically no difference out to 2 years whether they had surgery or PCI with a Taxus stent. In contrast, now we're starting to get approaching significant differences in event-free survival, again favoring surgery when you have intermediate lesions between 23 and 32. And now in those high-risk lesions with the Syntax score over 33, there's a clear benefit to surgery over PCI. The similar score exists for surgery. We can take the same patient that I presented to you before, the 50-year-old male, insulin-dependent diabetic. We can add triple vessel disease. He's having an elective coronary surgery. You can go on, you can Google this. It's called the online STS calculator, and you can plug in all of his variables, and it'll give you this output. It'll say that he's having an isolated coronary bypass surgery, that his risk of death with this group of risk factors is 0.6%, and it'll list every morbidity and mortality that you want to look at, the length of stay for administrative folk, with the risk of him having a prolonged ventilation, the risk of infection, et cetera, et cetera. You can also look at a more high-risk individual. So if you plug in a 70-year-old female, insulin-dependent diabetic, triple vessel disease, but now presents to you with a recent non-STEMI requiring urgent bypass, her risk goes up to 4.4%. Still very acceptable, I would think. But again, you can plug this in for your own individual patients, and sometimes it's eye-opening to say how low risk the actual surgical procedure is, despite what you might think based on their comorbidities. This is a randomized, so there's a meta-analysis of several randomized studies looking at PCI versus surgery for multivessel coronary disease, published in Circulation about 3 years ago. And again, very consistent finding that with a pooled analysis, if you look at overall survival or event-free survival, very little difference between PCI and Cabbage. However, when you look at the rates of repeat revascularization and event-free survival, including the need for repeat revascularization, a clear benefit to surgery over PCI. Again, what does your patient care about? Survival and the need for repeat intervention. If he wants to avoid repeat intervention, surgery is the way to go. So again, in this pooled analysis of 4 randomized trials, PCI with stenting was associated with a long-term safety profile similar to that of Cabbage, but as a result of persistently lower repeat revascularization rates in Cabbage patients, overall major adverse cardiac and cerebrovascular event rates were significantly lower with surgery out to 5 years. I'm going to focus a little bit now on some Ontario-specific data. This is data that was obtained in conjunction with the Cardiac Care Network of Ontario and the Institute for Clinical Evaluative Sciences. And you can see that the volume of diagnostic cardiac procedures has grown, as you would expect with the aging population, from 2007 to 2011. You can see that the growth in PCI has been evident. You can see that fully 40% or more of the patients having PCI are receiving drug-eluting stents. And you can see that the overall volume of cardiac surgery has been relatively stable, but it's because of an increase in the proportion of valve surgery that we're doing, and unfortunately we're seeing a drop-off in the number of isolated surgical revascularization procedures that are being performed. And if you put this another way, you're looking at the ratio of PCI to Cabbage across the province in the past 10 years, despite the publication of all of these meta-analyses showing that surgery is clearly superior. We're still telling our patients, don't worry about it. If you want PCI, have PCI, and you can see what we're at now. 3.5 to 1 is the ratio of PCI to Cabbage in the province of Ontario. However, I'm happy to say that all is not lost. In terms of Ontario comparing across the country, we're pretty much right in the middle of the board. You can see in 1994, we were actually one of the lowest PCI advocates in the country. We've now caught up a little bit. We're sort of middle of the pack with an overall ratio of 2.5 to 1 in 2005. There are some regional differences, and this is a study that's recently been presented and is going to be published very shortly. This study is called The Variation in Revascularization Practices in Ontario, and you can see that based on where you had your diagnostic cath, your risk of having a PCI is dramatically increased in the north at 6 to 1 versus Hotel Dieu in Windsor, 1.33. And I won't bore you with all the data, but I can tell you that they looked at the risk adjustment of these patients, so they're all the same patients. They're not different in Thunder Bay than they are in Windsor. They looked at the access to surgery, so there's no difference in waiting times in these centers to surgery versus these centers. So this is strictly because the operators doing the diagnostic caths in these centers felt that these patients, although they're identical, should have PCI versus these patients should have surgery. The interesting thing that came out of this, and this is a retrospective sub-study, they looked back at the charts of patients who had triple vessel disease, and they looked at their risk-adjusted survival at 700 days, and this is Ontario again, if this patient had PCI, and again, this was pretty much random based on what that institution's philosophy was, there was a survival benefit to surgery at just over 2 years. Let's look at some more dramatic examples of where surgery has a benefit. This is the STITCH trial, which Toronto General and the Peter Munk Center was actively participating in. Again, a multinational study specifically looking at coronary bypass surgery in patients with left ventricular dysfunction. We randomized just over 1,200 patients, 600 of whom were initially randomized to medical therapy, 610 initially randomized to surgery. The interesting thing is that over the course of the first year of follow-up, 100 of these medical patients eventually underwent surgery, whereas only 55 of these initial cohort of 600 patients, for one reason or another, didn't have surgery in the first year from randomization. If you look at the intention-to-treat analysis, in other words, they were randomized to medical therapy. How did they do out to 5 years? No difference, but trending to a p-value with a little bit of an advantage to surgery. But what's more important, since 16% of the patients initially treated with medical therapy actually had surgery in the first year. So if you redo the survival curves based on what the patient had in their first year, and then you follow these patients out 5 or 6 years, you now see a complete divergence of curves, highly statistically significant, and you can see the hazard ratio is 0.7. In other words, there's a 30% relative risk reduction to surgery compared to medical therapy in these patients with triple vessel disease and left ventricular dysfunction. So the summary of the major findings in this study is that there's a 19% relative risk reduction in death from cardiovascular causes, a 24% reduction in death or hospitalization, and a 30% relative risk reduction in overall mortality based on the treatment received. So, back to the patient. Why do your patients want to avoid surgery? Repeat revascularization? Well, again, I think I've shown you that there's no doubt that surgery is better with lower revascularization rates compared to PCI alone, whether they have stents, whether or not they're drug-eluting stents. Long-term survival, again, PCI has never in any study ever been shown to be superior to Cabbage in terms of survival. And the interesting thing is that most of the randomized trials that have compared PCI to Cabbage have restricted their inclusion criteria to a patient subset that never had benefit with Cabbage. So even if you go back 20 years to some of the early Cabbage versus medical therapy trials, patients with two-vessel disease never had a survival benefit with Cabbage, but we're now going to randomize Cabbage to PCI in that patient cohort and show that there's no difference. In certain subgroups, however, those with diabetes, those with left main disease, and as I just showed you, those with significant left ventricular dysfunction, it's been time and time again showed that surgery has been shown to offer superior survival. But they always come back to you saying, I want to get back to work. And it's the recovery from surgery that focuses me towards having a lesser procedure with an intervention. Well, one of the things that we like to do at the PMCC is innovate, and you're going to hear some of that later this afternoon. And this is what we're doing to try and address that concern. So there are multiple products out there on the market. This is just one of them. This is called the Sternal device. It's an active fixation device, so we're basically plating. If you went for orthopedic surgery, your orthopedic surgeons aren't putting wires in your long bones, they're putting plates in their long bones. So we're now doing the same thing with our patients who want to get back to an active lifestyle. Kryptonite is a type of bone cement that re-approximates the sternum within 48 hours, and we have patients doing push-ups 48 hours after bypass surgery when their sternum has been cemented with kryptonite. So I've had a construction worker who's gone back to full work 3 weeks after having bypass surgery with kryptonite, and we can allay that fear of having to be off work for 2 months because they're having bypass surgery. So in summary, I think there are multiple criteria unique to each patient that actually may dictate the optimal mode of revascularization. I think the use of these syntax and ST scores might be helpful in determining which mode of revascularization is appropriate for a given patient. I think patient preferences obviously have to be considered, but our job as their attending physician is to advocate for the best evidence-based treatment. And I'm happy to say that at Peter Munk Cardiac Center, we now have this integrated health team approach. All patients with complex or multivessel coronary disease are now going to be evaluated by a combination of non-interventionalists, interventionalists, and surgeons, and such that this approach is going to make sure that patient with multivessel or complex CAD has the optimal evidence-based therapy. Thank you.
Thank you, Viv. So I don't think you're going to hear a better discussion about the different range of options for treatment of coronary disease at any meeting. So that was truly fantastic. We're going to take a health break now. Please be back for 11 o'clock, and we're going to have a panel discussion. You can tell from the nature of the talks, you don't want to miss that panel discussion.